Welcome, everyone. Pour commencer, nos excuses, il y a eu quelques problèmes techniques avec la fonction d'interprétation du Zoom. Si vous n'êtes pas en mesure d'accéder à l'interprétation de l'anglais vers le français ou de français vers l'anglais, cela devrait être corrigé sous peu. So a brief announcement to say that we're having some technical issue with the interpretation function, but we expect that we're going to have that fixed very shortly. So thank you for your patience. We are going to begin our first simultaneous session of the summit. I am very pleased to introduce your moderator for this summit. So we have Mr. Delaney Hines. Delaney Hines is currently the Senior Manager of Health Equity and Partnerships at the Heart and Stroke and holds a Bachelor of Science in Integrated Science from Carleton University, a Master of Public Health from Western University's Interfaculty Program in Public Health at the Schulich School of Medicine and Dentistry, and a Master of Business Administration from Quantic School of Business and Technology. Delaney has over 11 years of experience working in public health research and most recently equity, inclusion, and diversity. His interest in advancing the equity of sickle cell disease care and health promotion activities such as genetic screening stems from his time supporting the Ethical, Social, and Cultural ESC program for the Bill and Melinda Gates Foundation's Global Health and Global Development programs at St. Michael's Hospitals and the International Network for Evaluating Outcomes, of neonates at the Maternal Infant Care Research Center at Mount Sinai Hospital. So you're going to be in very good hands with Delaney Hines as your moderator today. I'm going to turn things over to him now.
Thank you so much for that warm introduction, Dr. Brian. Much appreciated and really happy to be here, folks. So I have the pleasure as well of introducing you to today's session lead. Joining us all the way from Ottawa, we have Dr. Ewurabena Simpson. Dr. Simpson received her medical degree from McGill University and completed her pediatrics training and hematology/oncology fellowship at the Hospital for Sick Children in Toronto. During her fellowship, she also completed a master's in public health at Johns Hopkins Bloomberg School of Public Health. Dr. Simpson's major clinical and research interests focus on health systems improvement for children and adolescents with sickle cell disease and other hematologic disorders. In her role as Assistant Dean for the Office of Equity, Diversity, and Inclusion at the U Ottawa Faculty of Medicine, Dr. Simpson aims to strengthen faculty-wide approaches for supporting a diverse community of learners, staff, and faculty, and to prioritize principles of equity, diversity, inclusion, and belonging. She's a board member for the Black Physicians Association of Ontario and is also treasurer for Canheim. So without further ado, I'm going to turn things over to Dr. Simpson to lead us through today's session.
Thank you so much for that warm introduction, Delaney, and I'm so happy to be here. So thank you everyone for taking the time to be here, and thanks again to the SCAGO Summit organizers for organizing this wonderful meeting and giving me the opportunity to speak to you this morning. So the topic of my presentation today is anti-Black racism as a social determinant of health, and I'll speak specifically about the impact of racism on sickle cell disease. And so I'd like to start by acknowledging the opportunity, responsibility, and pleasure with which I endeavor to serve the children, youth, and families of the unceded territories of the Anishinaabe Algonquin people in the region we also know as Ottawa. I have no conflicts of interest to disclose. So there are three objectives for this presentation today. So firstly, I'll discuss the impact of racism on health outcomes in general. Then I'll describe the effects of racism on outcomes and treatments related specifically to sickle cell disease. And finally, I hope to clarify the role that healthcare teams, patients, and leaders can have in eliminating racism within our health system. So to start off, we'll begin with a discussion of the impact of race and racism on health in general. So what is race? So as you can see on the slide, race is defined as the idea that the human species is divided into distinct groups based on inherited physical differences and behaviors. In reality, though, race is a social construct. This means that it can't be defined biologically because of the genetic variations between human individuals and populations. The archaic concept of the 5 races is illustrated on the right of the slide, namely the African, Asian, European, Native American, and Oceanian races, and these categories still persist today. Human populations are broadly grouped into geographic regions, which are depicted by the ovals at the top of the figure on the right. But when we look at the complete genomes of people around the world, there's actually little variation between different regions. In fact, there's greater variation within regions, and there's actually no uniform identity that can be attributed to your geographic origin. Although our brains are conditioned to think that superficial differences will correlate with genetic makeup, here's some images to challenge that conditioning. Lucy and Maria Aylmer are from Gloucester in the UK and say that when they walk down the street, they're mistaken for just being friends. In reality, they're actually twins, even though Lucy appears to be white and Maria is Black. Marcia and Millie Biggs are also twins. Their father is of Jamaican descent and their mother is of English descent. Similarly, James and Daniel are also twins. It's amazing to think that this is even possible when in each of these cases, one twin has a skin tone that would be considered as Black, while the other looks white. It's important for us to recognize that racial identity can be fluid, and although an individual may self-identify with a specific race, this can be different from the race they would classify themselves as on a closed-ended survey, from how they are classified and are observed by others, from their racial appearance or phenotype, or from their racial ancestry. In the US and in Canada, the number of individuals who self-identify as being of 2 or more races is increasing. And for many of these people, racial identity is not static or binary, but it's fluid. Whether self-assigned or externally classified, racial identity will come with stereotypic associations, bias, and discrimination. In general, bias and discrimination will operate at individual and systemic levels of society, which will both create and limit power and opportunity between socially constructed groups. At an individual level, when we speak specifically about race-based discrimination or racism, it's a belief that race is a fundamental determinant that produces an inherent superiority of one particular race over another. Systemic racism is an interaction between prejudice and power, and it leads to the systematic oppression of certain individuals and communities to the social, economic, and political advantage of another race. For us to better understand the effects of race and racism on health outcomes, we need to review the social determinants of health. So what are these social determinants? Based on the WHO's definition, the social determinants of health are the conditions within the environments where people are born, where they live, learn, work, play, etc., and which affect health outcomes and the risks to health, functioning, and quality of life. So as you can see in this slide, social determinants of health can be grouped into 5 areas. So how do these play out for Black Canadians? So firstly, with respect to accessibility and quality of education, African Canadian children are more likely to be streamed into basic level academic programs rather than advanced level programs, and this will limit their employment mobility. When we speak about economic stability, based on data from the Wellesley Institute, Black Canadians earn about 75.6 cents for every dollar that a white Canadian earns. With respect to social and community context, in Canada, Middle Eastern and Black Canadians are disproportionately and negatively profiled by police and are thus overrepresented in the criminal justice system. For housing and environment, the poverty rate among Black Canadians is more than triple that of the average for white Canadians. And finally, even within our universal health system, when we speak of accessibility and quality of healthcare, African Canadians experience a high and disproportionate level of chronic health conditions such as hypertension, diabetes, cancer, and mental health conditions. When considering the social determinants of health, it's important to distinguish that racism and not race will drive the social determinants of health and be a barrier to health equity. In Canada, the 2 most blatant forms of racism are racism against Black people and our treatment of Indigenous people. In Canadian hospitals and other healthcare systems, Black and Indigenous people often face systemic discrimination and inferior treatment. As Canadians, we're known to consider ourselves as being more open and less racist than our neighbors south of the border. However, the reality is that our history is rife with examples of racism and its effects in our health system. A recent and terrible example of the reality of racism in medicine is the death of Joyce Echaquan at a hospital in Joliet, Quebec in 2020. Ms. Echaquan presented to the hospital with abdominal pain, and medical staff treated her with morphine while ignoring her assertions of a history of an adverse morphine reaction. She died, and the circumstances leading to her death are still being investigated. Prior to her death, though, she recorded racial slurs that were expressed about her by hospital staff. Brian Sinclair was 45 years old when staff at a community health center sent him to the Winnipeg Health Sciences Center to have a urinary catheter changed on September 19, 2008. 34 hours later, Mr. Sinclair was found dead in his wheelchair after waiting in the hospital's emergency room for more than a day without being seen. Brian Sinclair was, in essence, ignored to death. It was assumed by several hospital staff that he was not ill, but simply sleeping or intoxicated. These assumptions were made and remade over and over in the 34 hours while Mr. Sinclair sickened and died in a hospital ER. These are realities of our Canadian history and health system that we rarely talk about, but continue to influence the way that we treat our Indigenous people in this country. Another glaring example of racism in our Canadian health system happened at Queen's University. In 1918, the Queen's University Senate voted to ban Black medical students from enrolling in its medical school with immediate effect. It was only in 1965 that Black medical students first enrolled at Queen's Medical School after this initial ban. It was only in the fall of 2018 that the University Senate officially repealed the ban and then issued a formal apology in April 2019. That was 3 years ago. And it's not surprising that we still have an underrepresentation of Afro-Caribbean and Black students in medical schools across the country. In Canada, when it comes to racism in health, we observe delays in responding to the pain of Black patients, which has a significant impact on our populations who are affected by sickle cell disease. In Canada, we also observe that Black Ontarians have longer delays in receiving evidence-based services for psychosis when compared to Ontarians of white European descent. Based on 2016 data from the Mental Health Commission of Canada, Ontario spends less per person on the mental health of Black populations than white populations. And finally, there's a lack of race-based data, which limits our ability to actually evaluate the presence and impact of race-based disparities within our Canadian health system. In spite of these very negative patterns, it must be remembered that health inequities are unjust differences that can be eliminated or mitigated through collective action by healthcare professionals, patients, and society at large with the right mix of public policy. So these are disparities that can be rectified through intentional policy, education, and behavior change. We can intervene. When speaking of anti-Black racism, this is a specific form of racism that is directed at people of African descent and is rooted in our history of slavery in Canada. The brutalization of Jacob Blake and the murders of George Floyd, Breonna Taylor, Ahmaud Arbery, and countless others in the United States, coupled with the horrifying statistics about the disproportionate burden of COVID-19 on Black and Brown communities, has forced the world to reckon with how systemic racism conditions our survival. The COVID-19 pandemic has highlighted racial disparities in diagnosis and mortality rates related to COVID-19. So this is a slide from the Ottawa Neighborhood Study, which shows how Black and Middle Eastern residents of Ottawa are affected by COVID-19 during the early part of the pandemic, or how they were affected. The quintiles Q1 to Q5 represent the neighborhoods that were the least to most severely affected by COVID-19 infections in Ottawa. The bars show the proportion of Black and Middle Eastern Ottawa residents that resided in these areas as compared to their proportions in the Ottawa population, which is represented by the horizontal black line. From the figures, we can see that the proportion of Black residents increases significantly in Ottawa neighborhoods with the highest cumulative infection rates of COVID-19, where up to 13.1% of Ottawa residents in the hardest hit neighborhoods were Black, compared to only 6.6% of the entire Ottawa population that was Black. Similar trends were seen for Ottawa residents of Middle Eastern descent. So why are we seeing this? What are the factors that contribute to the impact of racism on health? We've already discussed the impact of the social determinants of health. And in Canada, although slavery was abolished in 1834, its effects persist as systemic and individual level racism. Unconscious bias and the way we train our healthcare professionals does not adequately prepare them to address and dismantle racism. I already spoke about the lack of race-based data, and we can't understand or eliminate the impact of racism on the health of Canadians without this information. At a government level, we need political will and interest so we can actually combat the impacts of racism in healthcare. And finally, we should have a healthcare workforce that is representative of the diversity of the Canadian population so we can better serve their needs and interests. Unconscious bias is a type of cognitive bias that has an important impact on the way that we interact with people and in the way that we deliver healthcare. As you can see on the slide, it's caused by associations or attitudes that reflexively alter our perceptions and thereby affect behavior, interactions, and decision-making. By definition, unconscious bias is automatic and is outside of our understanding or awareness. Whether we want it to or not, unconscious bias will influence the way that we process information and leads to unintended disparities in recruitment, patient care, and opportunities. Without intending to, many of us stereotype others based on our historical, learned, or anticipated experiences with individuals or groups of specific backgrounds. These automatic and often negative stereotypes come from unconscious bias and will form part of the hidden curriculum that we teach to students as they train to become healthcare professionals. Another major issue within medical teaching and practice is our continued use of race-based medical concepts. So what exactly is race-based medicine? Race-based medicine is defined as a system by which research characterizing race as an essential biological variable will translate into clinical practice. In hearing this definition, it may be hard to believe that race-based medicine is alive and well and persists within our medical education in Canada. However, I'll give you some examples. eGFR, or the way that we measure renal function, assumes that the normal GFR for Black patients is about 1.2 times lower than that for white patients. And as a result, Black patients may experience delayed dialysis and renal transplant referrals. Vaginal birth after C-section, or VBAC, has an algorithm that is used to predict the risk that would be presented by a trial of labor for someone who had previously undergone a C-section. This calculator consistently predicts a lower likelihood of success for anyone who's identified as African American or Hispanic, which leads to a higher rate of repeated C-section deliveries. Urinary tract infections and stones have algorithms for predicting the risk of kidney stones and urinary tract infections in the emergency department, and they tend to assign lower risks to individuals who identify as fully or partially Black, which makes these individuals less likely to be evaluated even if they have symptoms of a urinary tract infection or kidney stones. The rectal cancer survival calculator predicts that Black patients will have a shorter cancer-specific survival from rectal cancer when compared to white patients. As a result, clinicians may be less likely to offer interventions to those patients because they have a lower predicted survival rate. The last example is the Breast Cancer Surveillance Consortium risk calculator. So this will return lower risk estimates for all non-white ethnic categories, which potentially reduces the likelihood of close monitoring in those patients. So for all of these guidelines and risk calculators, they're problematic because they actually exacerbate the disparities that already exist for the health outcomes of Black, Indigenous, and people of color communities. For several of these algorithms, when we have tried to actually validate them, we see that the race variable was not actually predictive of disease risk. This makes several of these algorithms potentially harmful for Black and other racialized communities. In addition to the discrimination that affects Black patients, those with sickle cell disease will face additional stigma when seeking medical care. As a brief reminder, sickle cell disease is caused by a single point mutation that causes hemoglobin to combine into long rod-like stems and to deform the red blood cell into the shape of a sickle. This change causes the occlusion of blood vessels, which leads to damage of organs that are affected. To give a bit of history, in 1910, a dental student who was originally from Grenada presented at the Chicago Presbyterian Hospital with symptoms of fatigue, pain, and pallor. His blood sample showed sickled red cells with signs of anemia, which is the white space that you see on the slides. This was the first time that sickle cell disease was described in the Western medical literature. Since the discovery of sickle cell disease in 1910, our knowledge of this condition has grown significantly. These images come from a series of paintings by Els Nazar, who was a Haitian artist who had lived with sickle cell disease but recently passed away. These images capture the pain and suffering that are the hallmark of this condition. And although we've come a long way when it comes to our understanding of sickle cell disease, we still have a long way to go to achieve medical care and outcomes that are equitable. In North America, it's difficult to separate sickle cell disease from race. These maps show the similarities between the endemicity of sickle cell disease and malaria that's related to the protection that you have with having a sickle cell trait. Here it can be seen that most of the cases of sickle cell disease will be found in sub-Saharan Africa, but there are also areas of Europe and Asia that will have a high incidence of sickle cell disease. In North America, sickle cell disease affects mainly the Black population because of the legacy of slavery on this continent. However, as you saw on the map on the preceding slide, sickle cell disease does not only affect individuals of African descent, it affects people from South Asia, the Mediterranean, and those of mixed ethnicity. When it comes to racism and sickle cell disease, it's disturbing that individuals who have this condition are still too often described as drug-seeking and accused of faking their pain, which results in inadequate treatment and further suffering. When it comes to describing our patients, many healthcare professionals are not aware that the term sickler is actually used to depersonalize and stigmatize patients who have sickle cell disease, and the use of this term should be stopped. It's akin to describing an individual with leukemia by their condition, rather than describing them as a human being who happens to be affected by that condition. When we speak of recent immigrants with sickle cell disease, language and cultural differences can make it even more difficult when they're seeking medical care. In Ontario, it's been described that adult patients with sickle cell disease who present to the emergency room will experience longer delays in treatment and are triaged with lower acuity compared to pediatric patients with sickle cell disease and adult patients with Crohn's disease. This should make us pause and question whether within our universal healthcare system, racism is actually causing these disparities in treatment times. When it comes to expertise and treatment centers for sickle cell disease, there's a lack of professional support for those who are affected with this condition, which delays much needed treatments and increases the risk of life-threatening complications. Many individuals with sickle cell disease do not have confidence in the health system, and hospital visits will come with stress, stigma, and isolation, which is very discouraging for patients and really increases the risk of complications. When it comes to research funding, it's well known that research funding for sickle cell disease is inadequate. And until recently, there's really been a stagnation in the development of new drugs. When we compare sickle cell disease to a genetic condition that's more common in white individuals, in the United States, cystic fibrosis affects 1/3 fewer Americans than sickle cell disease does, but receives 7 to 11 times the research funding per patient. These disparities are related to systemic bias and inequity. Racism doesn't only impact how individuals with sickle cell disease are treated in hospitals, and also extends to affect those individuals who have sickle cell trait. So this headline comes from the New York Times in an article that was published in May 2021, when they published the results of an investigation that found that at least 46 instances over the past 25 years where medical examiners, law enforcement officials, or defenders of accused police officers had pointed to sickle cell trait as a cause or major factor in the deaths of Black individuals in custody. 15 of these deaths have occurred since 2015. When looking closely at these cases, in about 2/3 of the cases, the person who had died had been forcefully restrained by the authorities, pepper sprayed, or shot with stun guns. But sickle cell trait, which is a benign condition, was cited as the cause of death. As recently as August 2021, the lawyers for Derek Chauvin, the Minneapolis police officer who was convicted of murdering George Floyd, invoked sickle cell trait in an unsuccessful motion to dismiss the case against him, saying that the condition, along with other health problems and drug use, were the reasons why Mr. Floyd had died. Is this disturbing? Absolutely, but it's unfortunately very true. It's so disturbing that in May 2021, the American Society of Hematology issued a position statement which states that the detection of red cell sickling and sickle cell trait in vitro, in vivo, and post-mortem at autopsy is insufficient to label sickle cell trait as a cause of death, particularly given the rarity of reported deaths due to sickle cell trait. There's clearly much more that has to be done to limit the impact of racism on sickle cell disease. Sickle cell disease was discovered over 100 years ago, and hydroxyurea was first studied as a treatment for sickle cell disease in 1993. It took more than 25 years before L-glutamine was approved as an additional disease-modifying therapy for sickle cell disease. Regarding the life expectancy for sickle cell disease, although it has improved, it's not good enough. There's still a differential in overall survival due to limited therapies, social determinants of health, and inequity in medical care. Now, hearing of the levels of bias and discrimination and its impact on healthcare and on sickle cell disease, how can we do better? Is it even possible to have an anti-racist health system? The surge of anti-Black violence in the past 3 years has highlighted the problems of racism in our society and launched an international movement to raise awareness of anti-Black and all forms of racism. Anti-Black racism has been declared as a public health crisis by several Canadian public health and medical professional societies, and it requires urgent attention and intervention. The momentum is here, and the time to change is now. For us to confront the health disparities that are caused by racism, we should really understand the concepts of non-racism and anti-racism. I'm not a racist. I don't see color. My best friend is Black. These are phrases that many of us have heard and probably even said when we have faced problems related to racism. To be non-racist is to do nothing and not to do something. It's a passive rejection, opposition, and dissociation from behaviors, speeches, and ideologies that are considered to be racist. In the words of Sir Desmond Tutu, if you're neutral in situations of injustice, you have chosen the side of the oppressor. Being anti-racist will actually call for action. In the past 3 years, we've heard more often about the concept of anti-racism, but what exactly is anti-racism? Ibram X. Kendi, American author, professor, anti-racist activist, and historian of race and discriminatory politics in America, said that we have a choice. We can either allow racism to continue as racists, or we can confront racial inequality as anti-racists. Anti-racism, in contrast to non-racism, is active. It's the practice of identifying, challenging, and changing the values, structures, and behaviors that perpetuate systemic racism. This means that if we observe acts or policies that are intentionally or unconsciously racist, we must name and denounce that racism. When speaking of anti-racism, allyship is a critical concept that facilitates inclusion and respect in medicine and in society. Your peers and colleagues come from a mosaic of differences, and being an ally means understanding and respecting that diversity. Allyship is about having someone's back. It's an active and ongoing process of advocating, supporting, and being a voice for people whose voices aren't being heard. As an ally, you're not a bystander. As an ally, there's much to learn and unlearn to advocate for and advance the interests of those who are oppressed, underrepresented, or marginalized. In the context of racism, a true ally will confront racism as an anti-racist. For us to dismantle racism in medicine and in healthcare, we should consider the different levels where racism operates. At a health systems level, for our health system to become anti-racist, we must take concrete actions against racial discrimination. This means that we should recognize and name racism when it appears. We should identify our unconscious and overt biases, but we also need to address and call out interpersonal and systemic racism. We need to develop policies and systems so that we can report, prevent, and punish acts of racism. When it comes to research, we need to have funding that's prioritized to enable the study of race-based health disparities and the collection of race-based data. We need to recognize that racism and not race is a fundamental cause of health inequalities. When it comes to education of our students, workers, and leaders in the health sector, we need to educate our members to stop using the term sickler and similar stigmatizing vocabulary, and we should ensure mandatory training on racial bias and racism to limit the infiltration of unconscious bias on decision-making. For our patients and their families, we need to support and empower them by including them in different initiatives, such as anti-racism working groups and other similar initiatives. At a medical institutional level, for our medical schools to become anti-racist, we should move from a race-based approach in medical education and practice to a practice that actually addresses and mitigates the impact of racism as a social determinant of health. This means that we must actively counter race-based stereotypes and train our learners so that they can contextualize social and structural determinants of disease. In Canada, our Black medical students are also calling on the faculties of medicine to be race conscious and anti-racist. In June 2020, the Black Medical Students Association of Canada, or the BMSAC, disseminated short and long-term recommendations to the associations of Faculty of Medicine of Canada and all Canadian faculties of medicine in the areas of admissions, curriculum, and accountability to anti-racism. It's actually a very thoughtful and comprehensive document, and it now serves as a guide for many medical schools across the country. I'd like to bring your attention to the photo on the left. And this photo was taken at their inaugural meeting in February 2020. And as powerful and memorable as this photo is, I'd like you to think about it for a minute. They were able to fit almost every Canadian Black medical student into that photo. It's truly remarkable, and I hope that future photos will need an aerial view to capture the progress that these bright and amazing students are pushing for. For us to transform the interpersonal relationships and interactions in medicine, as healthcare providers and leaders, we must work towards building an anti-racist culture to confront racism while fostering diversity and belonging within our environment. So it's important to remember that this is not a Black or a BIPOC issue. This is a human issue, and it demands accountability from leaders and a deep commitment to action, but we all need to play our part. Finally, at an individual level, there's a great deal that we can do to move toward becoming anti-racist. Becoming anti-racist begins with personal reflection and will start from a place of fear and discomfort. By actively seeking to know and understand racism and its influence on us as individuals and as a society, we'll move from the stage of fear to learning and ultimately growing to becoming truly anti-racist. Where I don't completely agree with this diagram is that becoming anti-racist is not necessarily a linear path, but probably more of a cyclical one, because we can come and go between phases depending on the situation. It's only with intention and self-reflection, though, that we can integrate anti-racism into our medical practice and into our daily lives. So that brings me to the end of the formal part of this presentation, but I look forward to your questions, but I have a few take-home points. So firstly, racism is an important social determinant of health, and it's a barrier to health equity in Canada and not just in the United States. In Canada, Black, Indigenous, and other racialized groups will face systemic discrimination and inferior treatment within our health systems. When we speak about sickle cell disease specifically, individuals with sickle cell disease are often profiled and experience delays in treatment because of anti-Black racism, and this comes as a result of the history of systemic racism within our country. In spite of these negative trends, though, it's important for us to remember that systemic racism in healthcare can be dismantled. And this will be through strategic and data-driven actions by healthcare professionals, educators, as well as patients and our policymakers. I'm sorry, I'm not sure why my slides keep accelerating like that. But anyways, that brings me to the end of the formal part of the presentation. So I'm happy to take any questions, and I'll stop sharing at this point.
Fantastic. Thank you so much, Dr. Simpson. Not only was that informative, I took a lot from that discussion. It was comprehensive, well designed, and I'm sure our audience really enjoyed it. So as you mentioned, this is our time for the formal Q&A. So if folks would like to enter a question in the Q&A itself by way of the chat, or you can also raise your hand potentially, and we could allow you to take yourself off mute and pose a question directly to our session lead. Maybe in the interim, while folks are thinking up some questions to respond, maybe I could just ask a question of my own. I know we talked a lot about how we can, accelerate the movement towards an anti-racist health system. What do you think practitioners or citizens, need to build to adapt to more diverse community needs and essentially bring about a more responsive health system?
Well, yeah, that's a great question, and I think there are many facets to that, to the answer. In that, I think that having the ability to call out racism when it happens, I think is so important. And that means that we have to have a society that makes it safe to do so, or an environment that makes it safe to do so. And for us to do that, really, we have to embark on education initiatives to really educate the healthcare providers so that they're aware of these biases and their impacts and how to mitigate them, but also educating our patients and families so that they can be empowered to actually call these behaviors out, and that they have an outlet that they can go to report these behaviors when they occur, so that corrective actions can be taken. So that's one aspect, that we get to a place where we can say definitively to everyone and consistently that racism is not tolerated within our healthcare system. But then also, when we look at the representation of healthcare providers and the diversity of healthcare providers, there are gaps. And there are initiatives that are being taken across medical schools across Canada to try to improve the representation of Black and other racialized groups. But not only do we have to increase numbers, but also increase the safety of the medical training environment to support all of our trainees so that they can actually succeed and excel within the environment, so that they can help to provide care to those underrepresented communities that need it the most. So those are just two ideas, I guess.
Off the top of your head. Fantastic. I see a question has come in from the audience. It says, can you really expect colleagues to call behaviors out when it may bring consequences to them, particularly when behavior from those more senior or holding power?
Yeah, so it's a really great question. And I think, we really have to reflect on the culture of medicine, because we have this culture that is hierarchical, where not only when it comes to racism, but other discriminatory behaviors and forms of harassment or intimidation have been enabled and perpetuate within the culture. And I think that it's time for institutions to really take to really act out the zero tolerance policy that many of them say they have, so that individuals who have these behaviors are actually disciplined, and that their corrective actions that are taken consistently. Because you're right in that it won't feel safe to call out these behaviors if, in fact, the system doesn't protect the individuals who are victimized by it. So a lot of work has to be done, but I think that, in educating people as the first step, and then having meaningful policies that address these behaviors, I do believe that it can get better.
Beautifully answered. One other question has come in thus far. What are some ways we can work in an interprofessional team that is anti-racist? I often am the only racialized person on a mostly white team.
Okay, so yeah, that's a challenging one, and I can relate to often being the only racialized person on a team, and I think that it's not always easy to call out different behaviors, but I think that by virtue of being racialized, it doesn't automatically make you the most able or the most qualified, I guess, to lead an anti-racist team or initiative or effort. And I think that, with the mindset of having, cultural humility and acceptance and understanding. As a team, you could work towards trying to understand the perspective from which your patients are coming from. And then when there are inequities, actively trying to understand why these disparities occur, to dismantle those inequities, I think is an approach that, is not only anti-racist, but would help to help groups from various social identities. But I can understand, and I wonder if this is where the attendees coming from, in that, sometimes the expectation falls on the individual who's racialized to be the ambassador or to be the leader when it comes to being in an anti-racist space, but it shouldn't be the case. And, for all of our allies, that's where I talk about allyship and really, thinking about the different social identities of your peers and how the intersections can limit their ability to speak up or to deliver the best level of care, for example. So, allyship really, in the true essence, should enable the formation of an anti-racist team, if that makes sense.
Fantastic. We have time for probably one or two more questions, so I do want to impress upon the audience to take advantage of Dr. Simpson's time. As you can see, she's dropping gems today. So please feel free to enter your question in the chat. On that same vein of allyship, oh, perfect. Questions come in. Since you cannot really hope to change entrenched attitudes, but you can change behaviors by having consequences for specific behaviors, how, really and truly, how do you really go about bringing about that attitude change? Or at least, what are your thoughts on that question, Dr. Simpson?
Yeah, so another really great question. So education is part of it. And, there's been criticism around implicit bias or unconscious bias training, and that, in the short term, it does lead to improvements, but not necessarily long-term improvements when it comes to changing attitudes or behaviors. And I think that, part of the solution to that means that it's clear that it's not a one-time exposure to this type of education that is going to make a difference. And it has to be, from at all levels. So from the leadership all the way through to all levels of the faculty, for example, or an institution, for it to actually have a meaningful impact. And so in addition to education, you need to actually have tools that individuals can actually use to help them to speak out or to confront racist or other discriminatory behaviors, because it's not enough to just be aware, that these things happen, but you need to really have a way to address them. And for many of us, that's not something that comes naturally. So I think embedded with education is actual practical tools, but also policy to actually, I guess, sustain the longevity or the impact of these, or durability, I think is the word I'm looking for, of these attitude changes. Because if somebody, has a belief that is anti-racist, but they're in a system that doesn't support that, then with time, that's going to disappear. So there are many levels that have to change for the attitudes to be maintained. I don't know if that makes sense. It's kind of a long-winded answer.
No, I mean, it's great. I just wanted to let you know, so we're more or less at time, but Dr. Simpson, I wanted to give you one more opportunity to deliver a final thought, maybe to our allies in particular. If you could charge them with one action, one takeaway from today about how they can go about bringing about or advancing towards a more equitable health system for, for Black peoples and individuals living with sickle cell disease, what would that be?
I think, one of the most important things to help to become an ally is listening more than you speak, and, hearing the experience of your peers who come from underrepresented groups, and trying to get an understanding of their perspective. Like, I think that's powerful in being able to influence the way you look at different scenarios. I think that it's really important. And then, can I add a second thing?
Of course.
Yes. Okay. And there are many individuals who come from racialized communities who are passionate about this area and concept, but we can't look to those individuals to be our teachers. We really have to educate ourselves so that we can change our attitudes through self-reflection and really critically thinking about our biases. That's the only way that we can do better. So I guess
Beautifully said.
Okay.
Thank you so much, Dr. Simpson, and thank you to all of you, our audience members, for your attention throughout this really informative session. I do want to let you know that following this session at 12:10, we have the Human Rights Equity for Individuals with Sickle Cell Disease panel with two speakers, one being Delilah Rafai and Lisa Arneson, and that begin at 12:10. Thank you once again for participating in today's session on anti-Black racism as a social determinant of health and the impact of racism on sickle cell disease. I look forward to remaining sessions for today, and to all have a good rest of your summit experience.
Okay.
And thanks again, Dr. Simpson.
Yes, and thank you everybody for coming. Okay, thank you, Delaney.
Take care.
Okay, bye.